Good morning, everybody. I have no disclosures except my bias. 5 years ago, we abandoned conventional bowel preparation in my institution, and I went along with it, but I have to say, some days I'm still not very happy. We use enemas for the rectal cases, and sticking the stapling gun up when things aren't completely clean is still a very nice experience. Now, it's obvious that for something like colonoscopy, you need a full bowel prep. The fluid can be aspirated and you reduce the risk of explosion if you deploy electrosurgery. There is the aestheticism of having a nice clean bowel to make a nice clean joint. And it's always been felt that bowel prep would reduce sepsis and reduce anastomotic breakdown. Why should you not do bowel preparation? Well, it may not be possible because of obstruction. It may not be necessary in somebody who's having the whole colon and rectum removed anyway, and it may cause fluid and electrolyte problems in the very elderly. And most importantly, there may not be an evidence base. The traditional view, of course, was that anastomotic leaks were determined by the quality of mechanical bowel preparation. And there were animal studies in the 70s showing that bursting pressure was lower in the presence of fecal residue, perhaps due to collagenase activity. This was, it felt, translated to fewer stomas and easier postoperative management. But there have always been critics, and since this is a tripartite meeting, one of them was Hughes from Melbourne in 1972, who claimed that the risk of sepsis and anastomotic breakdown were no greater in unprepared bowel, and he felt that solid stool was less dangerous than liquid stool. There were some early randomized trials in the early 90s showing no difference in outcomes between patients prepared and non-prepared. And of course, bowel preparation is time-consuming, exhausting for the patient, and heavy on nursing time in the days when we used to admit people for their bowel preparation prior to surgery. And of course, there were a whole flood of different kinds of preparation. A bewildering choice of starvation, purgation, enemas and washouts. And if you read it, it just makes you feel ill. Elemental diets, whole bowel irrigation, distal preparation, on-table preparation, all have had their advocates. Interestingly, there's only one recent reasonable study on the physiological effects of bowel preparation from Kellett's group, published in DCR in 2004, 12 healthy volunteers, standard prep with bisacodal and sodium phosphate, and they showed a decrease in exercise capacity, a fall in weight, and an increase in plasma osmolality and a fall in potassium and calcium. However, their conclusion was that the adverse effects due to dehydration were small and may not be clinically relevant. So undoubtedly, bowel prep has an effect physiologically on our patients. But it was this systematic review that really made the difference and has changed practice probably around the world, I guess. And here you can see the results of pooled studies, 9 randomized controlled trials, and in the anastomotic leakage look in the bowel preparation group 6% and in the no prep group 3.2%, and as far as wound infection was concerned, both also significantly lower than those in the bowel preparation group. No difference in mortality. So this was beginning to say there isn't any difference in anastomotic leakage rate, and it may even be less, and there's probably a reduction in wound infection. Well, here are some of the forest plots from that Cochrane review. First of all, this is overall anastomotic leakage, and you can see that the bars are slightly to the right, favouring no preparation versus preparation. This has been stratified for colonic and rectal surgery. One of the criticisms of the studies has been the lack of evidence in rectal surgery particularly, and you can see here that for the main group in the lower part of the forest plot, the studies favour no preparation, and maybe it's not so clear for the rectal groups. And it's most interesting to see, of course, This data is based on 50 cases of rectal operations only. Similarly, from the top down, no preparation favours in mortality, peritonitis, and reoperation. So no preparation is favourable on all those grounds in that Cochrane analysis. So the conclusions of the Cochrane review were: there's evidence that it may be associated with an increased rate of anastomotic leakage and wound infection. The dogma that mechanical bowel preparation is necessary before elective colorectal surgery should be reconsidered. However, there have been criticisms of the Cochrane review. There were a wide variety of mechanical bowel preparation regimes used, and various sites of colon were pooled. As you can see, both colon and rectum pooled together, and there have been deficiencies described in the included studies. So since then, there have been a few more papers which I'm just going to present to you. Here's a study from Switzerland looking at elective left-sided resections, 153 randomized to polyethylene glycol preparation or no prep, and for sepsis, 22% in the prepared versus 8% in the non-prepared group, including leak abscess, peritonitis, and wound infection. Lower anastomotic leak rates, you can see there, lower other morbidity, and a shorter hospital stay, favouring the no preparation group. Here's the only study published so far looking at rectum only. It's a non-randomized comparison of 61 with mechanical bowel preparation versus 52 without. The overall morbidity was higher in those mechanically prepared. The anastomotic leak rate was equivalent. The post-operative stay was shorter in those not prepared. So some reassurance to those who feel that rectum surgery should still be prepared. Two more recent randomized controlled trials: Jung in 2007, open elective colorectal operations randomized, no difference in complications including anastomotic leakage, and in the Lancet in 2007, 1,431 patients randomized, no difference in anastomotic leak, but a slightly higher incidence of abscess after leak in the no prep group. There's one single dissenting voice in all this. Cameron Patel from Perth published in the BGS in 2006. He compared the use of a single phosphate enema as preparation versus 3 litres polyethylene glycol. These were colon and rectum operations mixed up, and there was a 4% versus a 0% anastomotic leak rate requiring reoperation. In other words, the phosphate enema group had a higher anastomotic leak rate than the full mechanical bowel preparation group. There was an increase in mortality in the mechanical bowel preparation group, but this wasn't statistically significant. So in conclusion, the balance of evidence now favours no bowel preparation. There is still some concern that the results of pooled studies looking at colon and rectum can truly be extrapolated to rectum alone, but I've shown you one study, a non-randomised comparison, suggesting that rectum can still safely not be completely mechanically bowel prepped. So there are still special situations. The low rectal anastomosis and the defunction colon may still require special measures to make sure they're clean before you do things, but on the whole, the evidence favours no bowel prep.